given the advanced time, I'd like to shorten my presentation a little. And the key is really that I'd like to focus on the issue of inequities. Draman has put some emphasis on financing and where to find the money. The question is where to put the money. And I skip this. I'd just like to point out this here. This is the age distribution of death in Sierra Leone and Denmark, to look at some extremes. If you look at Sierra Leone, about 50+% of all deaths occur in the age group of 0 to 5. So if you look at the 100 coffins produced in Sierra Leone, half of which are about the size of like this. If you look at Denmark, in contrast, basically nobody dies between the age of 0 and almost 20. And deaths only occur after the age of basically 40, and then of course go up and then down again. So that gives you an idea of a country where you have extreme high infant and youth mortality rates, and here you have a country, a well-advanced country, very economically and socially advanced country, where people really start only to die at a later age. Also, we've discussed it before, the likelihood of a sub-Saharan African woman to die because of pregnancy and childbirth is 1 in 16. Okay, so I guess there are about what? 50 women here. 3 of them would be dead just because of pregnancy and childbirth. Totally avoidable deaths. In contrast, if you look at developed regions, it's 1 in 3,800. Quite in contrast to the burden of disease, if you look at high-income countries and low- and middle-income countries, population is 85% in low- and middle-income countries. The burden of disease is even a little bit higher. We're talking about roughly 90% of burden of disease occurring in low- and middle-income countries. And quite in contrast, only 10% of the money available is spent in those countries. Global health spending, this is 2002 figure, never mind. It's roughly still about 10% of global GDP. And the interesting thing is, like military spending, half of the spending comes from the United States. Half of global health spending is in the United States. When you discuss about who should pay, there used to be quite a bit of discussion of a socialist versus a capitalist. You know, it's a special good, society should pay. No, it's a private good, the individual should pay. I think we've gone past that, and now we are talking about the human rights perspective. In a sense, it's a human right to receive some, however defined, decent form of health care. And that's what it is all about, and there are the 4 criteria, some of which were mentioned already by Draman: availability, accessibility, acceptability, and quality. And I'd like to point out this acceptability bit, which is often forgotten. It means you provide types, levels, and modes of healthcare that people actually want and that are acceptable to them. You just don't simply transfer, say, Western Europe methods into, I don't know, Northern Africa or Southeast Asia or wherever. We had social health protection. I'd like to point out public or publicly organized and mandated. I think that's the key. We are talking here now about something where the public takes control. And the minute the public takes control, if you have a public institution, you talk about fairness and justice. If you don't, you may as well leave it to the market. Why bother? Okay? If you say, I do want something to do about it, and I do want the public to be involved and to manage, then you have to talk about justice. The 3 goals of any healthcare system: health status improvement, obviously. You want to be healthier. But likewise, you want to make sure you're protected from financial risks, something, again, Draman pointed out in his presentation, and what is called social responsiveness or acceptability, in a sense that the system delivers care people want. All the other bits, equity, efficiency, sustainability, financing, they are sort of intermediate goals. Nice to have, yes, important, you can measure them, but at the end of the day, they don't count in a sense that what you really want are those final, ultimate goals. When it comes to financing, it's getting a bit difficult and complicated. What are the original sources of funds? What are sort of intermediaries like insurance systems, and who are the providers receiving the money? And as you can see, arrows go from everywhere to everywhere, basically. Government is a sort of intermediary. I tend to say electricity doesn't come out of a socket. People tend to think so. Yes, government should do this, and government should do that, and government should pay for this and that. Well, government can only do where it has money for, or what it has money for. Government needs what is called fiscal space, extract money from individuals, from companies to be able to fulfill all the myriad roles that people ascribe to government. Essentially, basic financing only comes from either households or companies or externally donors, charity, or something like that. If you talk about societal values, if you talk about justice and equity, the key thing is you contribute according to your ability, you receive according to need. And that's what is called solidarity in Western European countries. But if you look here, I put a list together. I'm happy to add. It's Bayanihan in the Philippines, Gotong Royong, Indonesia. Don't ask me to pronounce this, okay? Harambee or Ujamaa in Kenya and Tanzania. Rentai in Japan, Tatamun in Arabic. I'm sorry, I'm lost here at the Burmese version. And in Urdu, we also have something. So if you think about it, almost any society has a certain term denoting what we call solidarity, that you take care of the others. The interesting question is at what level? Usually we say at a national level, but in some society it's at the family level, it's at the village level. It depends. And the question is, hence, where do we organize social security at what level? If we talk about contribution according to ability and care according to need, it's quite in stark contrast to private health insurance, because in private health insurance, contribution according to risk and receiving care according to the contract. And if you have a problem, pre-existing lower back pain problem, the insurance company will say, we exclude this, which is, of course, not the idea of a healthcare system. If you look at contribution according to ability, how can you measure? The instruments to use is called financing incidence analysis. I'll come to that later. It's a bit of a lingo here, FIA, or also called progressivity analysis. Those who earn more should contribute relatively more, not only totally more, but also in relative terms, a higher percentage. Likewise, if you look at the receiving according to need, we talk about the benefit incidence analysis. Do people in different strata of the population receive similar levels of care? The problem is here we can't take into account who is particularly ill and would need more care, but we'll come to that in a minute. If you just look, for example, at coverage rate, here you have the timelines. Here you have different countries, some Middle European countries, Southern European countries, then Asian countries, and so on. Does universal coverage is all there is? No, there isn't. Because if you look at Rwanda, universal coverage has been achieved remarkably well within 10 years, basically. But out-of-pocket expenditure remains stubbornly high at over 50%. So in a sense, it doesn't mean just that you achieved universal coverage, you have successfully tackled the issue of out-of-pocket expenditures. There is no direct link. There might be, but there doesn't have to be. There's an example from Cameroon, pumping more money into the system from international donors. This is here, annual budgets going up. Likewise, maternal mortality rates go up. That's what you don't want. You want to go them down. Okay. Now, hot off the press, basically, a book by WHO monitoring health inequities. And that's sort of the standard where many countries may say, yes, let's try to use this. And they say, if you look at inequalities, they exist across countries, but also within a country. I think all of you are well aware of it. If you're poor, if you're rich, dramatically affects the likelihood of a child to survive its first year of life. Inequalities may change over time. Inequalities have many faces. Yes, it's a gender issue, it's an education issue, it's an income issue, and so on and so on. And the reduction of inequality should be an explicit aim of health agendas and goal setting. Here we go, which I believe makes a lot of sense, but there's a but. Look at this, economic status, and here we have death per 1,000 live births, a classical indicator, infant mortality rate. The richer you are, the less people die. The better educated the mother, the less children die. If you live in an urban place, less children die. Male, female, this is minuscule, but there is a difference. However, let me point out this here. Data are not available. You see that quite often, and I'll come to that. That's an extremely important issue, I believe. Likewise, if you look at ILO, loads of data, deficit of population coverage, out-of-pocket payments, exit deficit indicator, maternal mortality ratios, and so on and so on. You need data to be able to indicate where does a country stand in comparison to other countries, but also within a country in different socioeconomic groups, and where is a country heading to. Here's the critical bit. A very good book by Morten Jerven from Denmark, published September 2014, Data for Development. The new bit is now data-driven development. Everything should be data, everything should be evidence-based, everything should be based on solid data. What about this solid data? What they want is, he looked at the experience with Millennium Development Goals monitoring, MDG monitoring, over the last 15 years between 2000 and 2015. What you would need is some sort of population census. On top, you should have some sort of demographic and health survey, DHS. On top, you need some sort of living standard measurement survey to understand, you know, the different strata of the population. And you also may want to have some sort of core welfare indicator questionnaire. No need to go into the detail, but all of you could easily imagine you need a lot of data just to assess which socioeconomic status you belong to, but also how much money you had recently spent on health care, whether you had approached a health facility or rather not due to financial considerations, etc., etc. What would it cost to get such data? Again, I won't go into the detail, but the interesting thing is just to do a census every 10 years. Depending on the size of a country, it will range between $1 and $3 per person. And if you, my favorite example, if somebody from Indonesia in this room? Anybody from Indonesia? Because my favorite example is Indonesia, a country with 18,000 islands, about 220 million people. What they repeatedly said, about 30% of births in Indonesia are not officially registered. How can you possibly manage inequity in Indonesia if you don't even know how many people there are? Let alone what socioeconomic status they have, let alone what health status they have, and so on and so on. Okay? So just to count these people, $3 per person. But I would imagine doing this in Somalia or Democratic Republic of Congo might be even more expensive due to the many difficulties enumerators would encounter in countries like these. You have a safety issue, you have geographical issues, and so on and so on. So, conservative estimate by Morten Jerven was, if you do that, you need $27 billion over 15 years. That is about what did he say? 5 times as much as Denmark gave in total aid during this time. Where do you find that money? Just to do the basic fundamental funding for having good data available. So this is something I would like to point out to you because I believe it's an extremely important issue. And I just, if you go back, just as an exercise, do what we've done in the class. Check the GDP of your country. Check it with WHO, with World Bank, with IMF, with your local statistical office, with your Ministry of Finance, with your Ministry of Economic Development. You'll find 5, 6, 7 different figures, sometimes considerably so. Just this apparently simple measure of gross domestic product. Or look at the number of people apparently living in your country. There will be 20% difference according to which source you're looking at. So what do we need? We need sufficient funds and quality to the different points of care. Sorry, this is Nepal, this is Tanzania, and this is Cambodia, I think. And I think it makes a lot of sense to look at whether you are in a rural area, whether you are in an urban area, or whether you look at a capital in a country. Quite different settings, quite different needs, quite different ways to attract good people, to attract well-trained staff and additional funding. Likewise, you would like to tackle disparities within a country, say urban and rural or rich and poor. Here we have the relation between the use of services between richest and poorest quintile in some selected Asian countries. I took the data from Ravi Ranan Elia from Ceylon, Sri Lanka. The richest 20% of women are 5 times as likely to use skilled assistant at birth in comparison to the poorest 20% of women. And that goes down to ORT therapy, where the difference is very limited but still exists. But look at this. This is 5 times difference, and this is what I call inequity. Another one is, does the money reach all parts of the population? So, if we say the poorest quintile share of inpatient care service, the poorest 20%, if you say you want just an even distribution of money of services, the poorest 20% should receive at least 20% of services. Assuming that the poorest 20% are probably more ill than the other parts of the population, you would ideally see a little bit more than 20% of inpatient services allocated to this strata of the population. What you see here, Hong Kong, at that time special administrative region, doing very well with about 40%, going to the poorest 20%, likewise South Korea. But if you go down here, Bangladesh, here we've got India or even Indonesia, you see an appalling 5–8% of the money going to the poorest 20% of the population, indicating, without having to do a detailed benefit incidence analysis, that those people do not even receive their fair share of the total. But these are the things you would need to show people what's going on, to show politicians, look, they don't even get what they're supposed to get, let alone what they might need because of lower levels of health. It's confusing, it's complex. This is an example from, it's a general example from Markus Löwe from the German Institute of Development. If you have like this is like France before the revolution in 1789, okay? You have the poor people here and the very rich over here. What you have is a broad and very multifaceted, complex way of how people, receive healthcare and pay for it. You have the informal sector here. Don't forget, informal sector doesn't mean it's poor. You have extremely rich informal sector people, lawyers, doctors, things like that, business people sometimes. At the same time, formal sector probably means you're not ultra poor, but formal sector might mean you're just about be able to make a living. Okay? So what it means is also some people take out commercial insurance, group-based schemes, especially in the informal sector. You might have social assistance and subsidized health. You might have some sort of social insurance. A particular problem is, especially I had a project in Indonesia, the so-called informal near poor. They fall out of the social assistance and subsidized health, but also they are not into the formal sector arrangements. They are informal, but they are near poor, somewhere here. A large chunk of the population. How do you assess these people? How do you access these people? How do you make sure these people receive adequate care? So what you would like to do, if it's a complex topic, any simple solution is of course wrong. So you need a complex, multifaceted solution. We don't have to go into this, but you would have to tackle it from different angles with different instruments to try to find ways and means to get as many people covered as possible. And also some technical help is at hand. Just to finish the presentation here. Brand new again, 2014 September, 10 best resources for conducting financing and benefit incidence analysis in resource poor settings. Something I strongly recommend you to have a look if you're interested. They present the basic concepts of FIA and BIA and how to do it in a resource poor setting to get some basic data for health policy, for administrators, for politicians to make decisions, and so that you can show them, that you can visualize to them where are the real needs in the country. And it's definitely not about just simply looking at overall healthcare expenditure, but there's a strong need at least to look at different economic strata of the population. Right, with this, I thank you.